we're providing something of value. And so I'm turning it over to Dr. Jasmine Clark, who I thanked earlier, who really, has been so important to Eddie and I. Eddie went to one of the meetings and found her, and she took Eddie under his wing, and then she's been just as helpful to me. And so, without embarrassing you too much, Jasmine, your turn. So she's
Yeah.
going to lead us in changing laws and making things possible.
Yeah, absolutely. Thank you so much. And thank you to so much to everyone who has stayed along. I know this is a lot of information to bring in, so please bear with me because a lot of what I'm going to share today really piggybacks off of what Natasha just provided for us. So I think it was a great segue into my presentation. I'm going to go ahead and share my screen and jump right in. All right, now I got to figure out how to do a presentation. Sorry, y'all. I can't actually, oh, there it is. I couldn't find the little thing that says turn it into a presentation. This is not a long presentation, and I hope that it is informative. Some of what I will share today is going to feel like you just heard it. I am a professor at Emory. I teach biology, and I am always of the mindset that you got to hear something really like 3 times before your brain really absorbs it and decides that it is important information to store. So it's okay if we hear a couple of things more than once. But what I would like to talk about today is really talking about that financial piece to making sure that community health workers, and in this case, what I'm going to talk about specifically is peer specialists that would work with gun violence victims, making the case for why they should be eligible for Medicaid reimbursement. And this is something that I will also pursue um, legislatively as well. All right, let's see if it'll let me. I don't know how to get this thing to let me change my slides.
If you click on the slide, will it move it? You just with your mouse?
No, I have a pencil. I think I don't know what's going on. Sorry, hold on. Let me get rid of this. All right, there it is. All right. So, what I'm going to focus on today is really the hospital-based side of things, although what I am seeking to do, hopefully will be able to go beyond the hospital. But for now, what I've been really focused on trying to provide is, um, you know, a peer specialist model that works through hospital-based violence intervention programs. And so many of you may know that hospital-based violence intervention programs like Ivy at Grady are multidisciplinary programs that include medical staff and community-based partners to provide safety planning, services, trauma-informed care to violently injured people. And I think that it is these programs are necessary. And there's a lot of data that shows that these programs not only are necessary, but they are effective in what they do. And so um, what they do, so basically a person who has been a victim of some type of interpersonal violence, community violence, are usually at a elevated risk for re-injury and violence perpetration, especially young Black males. And so when that victim is in a hospital or healthcare setting, there are studies that show that this individual, is particularly receptive to a lot of the interventions to get them out of what we call a quote cycle of violence. And so in these violence intervention programs, these victims can get community-based services, mentoring, home visits, follow-up, long-term case management. And these are all going to look different across the country and in different places, even across different healthcare systems. But the goal is that these intervention programs are there to get to the person, the individual that has been affected, and try to prevent them from being affected again, re-injured, or a lot of times what we'll see is retaliation, and we don't want either of those to happen. And a lot of times, a lot of these factors are determined by what we call social determinants of health. Um, Social determinants of health, in a nutshell, are the things in your environment, the things in your community, the things that are in your life that affect your health that aren't the things that we normally think of. So we think of like, oh, the things that you eat, or, you know, how much exercise you get, as like, oh, those are the things that affect your health. And yes, they do. But social determinants of health might go beyond that, and not just the things that you eat, but the grocery stores that you have access to, and whether or not you have access to things like fresh produce, or whether the place where you get all your groceries, everything is processed, everything is in a box or a can, and there is not a fresh produce section. That's an example of a social determinant of health. Or even if you have access to a grocery store, do you have access to transportation to get you there? When we talk about, oh, well, people need to exercise. Well, sometimes a social determinant of health could be, I would love to exercise, but we do not have gyms in my community. And the gyms that are there are so expensive that I wouldn't be able to go there even if I wanted to go there. Or maybe there's violence, or there's things that are happening in those places that make it to where you don't feel safe going there. So it's not about the fact that you don't want to exercise, it's that there are things in your social environment that prevent you. So those are the types of things we talk about when we talk about social determinants of health. And violence intervention programs have the ability to address some of those social determinants. So I want to talk about peer specialists today, and we've heard a lot about peer mentorship, and we've heard from victims, we've heard from caregivers of victims about why peer mentorship is so important and how helpful it is. How helpful it is in just knowing, hey, I can do something that I thought I'd never be able to do before. Or, hey, there's someone who has been through this, and they understand why I look over my shoulder every time, you know, this certain thing happens, or I hear a loud noise. They get it, they understand. And so a peer specialist, as we've talked about, is a person who, through their lived or shared experience and training, provides support, encouragement, and guidance to individuals seeking mental health or substance abuse support. And I put that here because that is Georgia's definition of a peer specialist. And so Georgia does have a certified peer specialist program in Georgia. They have a training, they have a certification, but those trainings and certifications specifically look at mental health, substance abuse, and sometimes youth intervention when it comes to those two things, mental health and substance abuse. And because Georgia does have a peer specialist program already through the Department of Behavioral Health and Developmental Disabilities, also known as DBHDD, that's how I refer to it from now on, Georgia actually led the way on this. Believe it or not, Georgia was the first state to request and receive Medicaid reimbursement for peer support as a statewide mental health rehabilitation option service. They did this back in 1999, and they led the way. And now pretty much every single state in the United States has some sort of peer specialist Medicaid reimbursement. So, you know, that's a great thing. And, you know, they celebrated their 20-year anniversary in 2019. And at that celebration, they celebrated having trained over 3,000 certified peer specialists or CPS individuals by that time. So that was what we're now in 2025. So that was 6 years ago. So it could be even more now. That was just the latest data that I was able to pull. So the idea of Medicaid reimbursement for peer specialists is not new. It is not inventing the wheel. It is not asking for something that has never been done before. So then what am I asking for? You're probably like, well, if we already have it, then why do we need it? Right now, as I said earlier, the certified peer specialist works specifically in mental health and substance abuse. But we recognize that gun violence is a public health issue and honestly, a public health crisis. And therefore, I propose that we should create or support a peer specialist model for gun violence prevention and make those peer specialists eligible for Medicaid reimbursement, just like the other ones are for mental health and substance abuse. So again, when I as a legislator, a lot of times the first thing I do is look to see, is anybody else doing this? And the reason why I do that is because a lot of times when you propose something, some people lack the imagination to believe that it can be done if no one else has ever done it. But the good news is 7 states have passed legislation that allows Medicaid to reimburse services that involve violence prevention, and other states have been able to get Medicaid reimbursement without having to do it through laws. So those 7 states, and this is going to be geography for me, so I don't have them written down, but I have them on this map, are Oregon, California, Colorado, Illinois, and I'm going to start over here, New York, Connecticut, and Maryland. And then I have an asterisk next to North Carolina because they have legislation that has been introduced that is pending, but it's currently not, has not passed as of when I did this research. So 7 states plus North Carolina. So I say all that to say we are not trying to do something that is completely unheard of. And other states recognize just how important this could be for violence prevention and intervention. And so the reason why I think this is really important is because that a lot of times the barriers to getting this done is one, lack of imagination and lack of funding, but also I think it's important because of what Natasha presented earlier. We have community health workers out there that the difference between them being able to serve their community that they're serving and not serve their community that they would love to serve is availability of funding. And so we really need to find a model that allows for consistent care for the individuals that are being served by these community health workers. And to be clear, a peer specialist is a community health worker, to make sure that that is consistent because continuation of care is important. It's important for people. And it should not be up to fundraisers or just grants that have a beginning and an end, and you have to hope that it gets refunded again, later. It should not be, that's not the model that we should be dependent on to make sure that individuals who need this care get this care. And so, again, I told you I wasn't going to spend too much time on this because I would love to take questions about this. Some ideas that I have been working on. So I looked at how other states did this or what other states do. And some states did this by starting with pilot programs. Pilot programs are usually a good segue into getting an actual program. The pilot programs basically just allow the data that justifies that this is something that we need to do long term. I'm going to pull up my notes now. I tried to do everything off memory, but I'm not that good. Let's see. In some states, that is how they started. That is the way they got this started before they went into it. For example, California started with a pilot program in 9 counties, and now they are able to offer Medicaid reimbursement for peer specialists. Right now, the state of Georgia does have a certification for peer specialists, specifically for mental health and also for substance abuse. And they also have a forensic one that is for helping individuals that have been incarcerated kind of re-enter society. And they have a program for that as well. But we do not have one that is specific for either violence or, in this case, gun violence in the state of Georgia. And so that is another thing. I don't know that that needs to necessarily be done legislatively. It could be done administratively through the Department of Community Health or through DPH. However it needs to get done, that's one thing that we would need to do to get us on the way to making sure that we can get Medicaid reimbursement for these individuals. And then after that, basically legislation to empower the state to seek the federal authorization from the Center for Medicare and Medicaid Services to provide the Medicaid reimbursement for community health workers, or community health worker services. And I don't know that Georgia Code currently defines community health worker, but that would be something that would need to be done. And gun violence prevention peer specialists could fall under that definition. But also, for this particular one, when we talk about getting reimbursement for community health workers, that's how Colorado did it. So Colorado basically created an umbrella term that of community health worker. They put it in their code as these are people who are eligible for reimbursement for Medicaid. And a lot of these reimbursement, they're similar to how Medicaid works for anything else, fee for service or managed care. Usually they're somewhere, some states were about $45 an hour. I've seen it go all the way up to over $100 an hour for services. Either way, after being on this panel today, and I listened to every person throughout this time, I am even more convinced that this is something that needs to be done. Number one, because of the importance of peer mentorship, but also I think that this is really important because we recognize that a lot of barriers to people getting access to the things they need or the things that will actually help them on their new journey, a lot of these things boil down to money. And right, if we were to create a peer specialist model that allows for these now new certified gun violence prevention peer specialists to get reimbursed, this is now a new avenue for individuals who maybe they were doing a job that required them to use their hands and feet, and now they no longer have the ability to do those things. There's now a new avenue for them to also get income working with hospitals and organizations to provide provide this and work as a peer specialist. So that is all I have. Sorry, one last thing. There are some barriers. Unfortunately, there are some people that do not like the idea of Medicaid funding any type of gun violence prevention programs. Our lovely congressman from the 9th, Andrew Clyde, did introduce a bill that would basically prohibit Medicaid from reimbursing these hospital-based gun violence intervention programs with the idea that, in his words, he felt like these were secretly anti-gun programs, but I don't think that that should be viewed as a true barrier. I think it should be viewed as maybe a hurdle that we might have to jump over, but not something, it's not a wall. And then the second barrier is always funding and making sure that we can make the case that funding this or budgeting this is actually going to save the state money in the long run. And I think there's plenty of data to support that. But again, another barrier, or sometimes as a legislator, I often find that whenever you have an idea, the first thing people ask you is, how much does it cost? And so just looking at that and being prepared to answer those types of questions as well. And so speaking of answering questions, I would love to take any questions if anyone has them.
Thank you very much. There's one here in the chat from Heather. If you want to ask it yourself, you can speak up.
Yeah, thanks so much. And thanks, Representative Clark, for all of your advocacy and working on this. We work with the States United to Prevent Gun Violence, and actually have a bunch of resources on other states who have been able to secure Medicaid funding for the CVI work. And my understanding, and I've been talking with, I don't know if Brent Bailey is still on here, but Brent Bailey with Community Justice Action Fund, about exploring this in Georgia. My understanding is that because we have not expanded Medicaid here, that it's just going to be really hard. And Stuart Portman is the Medicaid director. Would love to have conversations with him, like paving the way towards this funding. But I don't know if you have any insight into that. But I'm happy to connect. I think maybe, and I saw that that Dr. Smith was also interested, and maybe we should get together and just have a conversation, connect our heads on this, because it just seems like the lack of expansion of Medicaid is going to be a limiting factor. But since I do know, I've had these connections to the people who've worked on in other states to secure the funding, would love to at least put our heads together, because it definitely is an avenue that we need to explore.
Yeah, absolutely. So I want to address, yes, Georgia is one of the few states in the country that has not expanded Medicaid, which creates a huge barrier to doing things like this. And so again, as I talked about on the barriers slide, funding is always like probably the number one barrier. What Georgia has not done is fully expanded Medicaid. But what Georgia could do, and I do think some other states have done, and I can go back through my notes, is seek waivers. And a lot of times a waiver program, or even a waiver for a pilot program, things like that, are a lot easier of a hill to climb in Georgia when it comes to these things, versus what feels like a Herculean effort to fully expand Medicaid completely. So that's one way to do it. I am right now so I consider this a 2-year project. So we just started the session. This is not going to happen by April 4th, 2025. But the goal would be to start the conversations now. I am right now in conversations with the Department of Community Health, but would love to chat with others that are already in the space that can maybe really even articulate this even better than I can, what I need to actually be asking of Department of Community Health. Because any bill that has to do with Medicaid, it's not going to be a bill until Department of Community Health says it's going to be a bill. Like, it's just not, it doesn't just happen because you want it to. So yes. All right, and I would love to link after this. So I'm so glad that we're all here in the same place. Dr. Randy, I've heard so much about you from Eddie, you as well. I think all of us kind of getting together and putting our heads together to figure out exactly what the ask is, and also just what are the different routes to get there. But the goal to me is to just try to get there, because I have found a lot of times when you talk about things like this, there are a lot of people that say, yeah, that's never going to happen. And then like no one starts because it just feels like it's just too hard in Georgia. But I think that there are people that can see this for what it is and ways that we can work it to get something moving. But, we'll definitely have to see.
Thank
And
you.
thank you.
This has been the reason for bringing all these various stakeholders together. It's very strategic as far as reaching out to the different groups, and people that I think maybe should have already known each other really hadn't known each other. So it's one of the good things I'm good at is networking and bringing people together. Natasha, you had your hand up.
Yes, I just wanted to kind of piggyback on the conversation that was just happening and add some more information around that. Although we are not a full Medicaid expansion state, there are over 2 million people in Georgia that are on Medicaid. So this is, as Dr. Clark was saying, this is kind of a good first step to start trying to ensure that community health workers have the funding that they need. Many of our federally qualified health centers see primarily Medicaid patients. So they need the funding to be able to, again, implement those community health worker models. So this is a strong first step in Georgia, is, again, as Dr. Clark said, expanding that scope outside of just mental health, but into other aspects to address all social determinants of health. And the question from Kelly in the chat, how can this be messaged to get to a very divided Georgia legislature? I think that this conversation around community health worker support, even given the most recent update from the governor around his healthcare priorities, I think people are understanding that there is a need for a workforce to be able to connect directly to people. And this seems to be, so far, knock on wood, Dr. Clark will know, but seems to be a bipartisan issue as far as getting support to people. But we still have to be careful in the messaging. So we are being very strategic. And not even, it's real. It's a workforce development issue as well. We have a shortage of providers in our state. We have, a shortage of care providers in our state. So this is an opportunity to create jobs in rural parts of our state and underserved parts of our state for people looking to give back in their community, but also get paid to do that. And also, again, kind of start closing some of those healthcare gaps that we see statewide with this workforce. So messaging it as a workforce development issue is definitely helping to kind of perk up the ears of those who will help get the bill passed. And Dr. Clark, I'd love to talk with you and Heather about how we can engage DCH to understand the value of this workforce and the need for reimbursement.
Yeah,
I love
absolutely.
that.
Our little powwow is growing.
Yes.
So yes. But yeah, I wanted to also really quickly add to that answer. I 100% agree. In the legislature, a lot of times you have to say the right words to get things to go in the right direction. And so, whereas I see this as a gun violence prevention, and I see this as, a care issue, truthfully, right now, the buzzwords in the Georgia State Capitol are economic development. And anytime you can make the case that it helps rural Georgia, it brings people together. So
This is wonderful because this is the way I see it. I see, I mentioned in the chat, we talked about unemployment. So many of our people are underemployed, and so between the unemployment and the underemployment, and we end up volunteering. I volunteer most of my time um, uh, for various reasons, and so workforce development is an important part of this formula. So thank you very much.
Can I, Dr. Tupper, I'm just going to jump in and say that at Georgia Majority, we're kind of trying to streamline all the different advocacy groups working on gun violence prevention. And I've been talking just to address the I guess, political divide. We are trying to stress just building a culture of responsible gun ownership. So it's, rather than being anti-gun, it's more creating this framework, this culture of responsibility. And, as far as like funding is one of the biggest ways that we are advocating, because it's not really about changing laws. I put in the chat like our legislative priorities, just so that people can see. Would love to have all of these really important voices join with us. Gun violence is an extremely expensive thing for our state. So some of these, gun violence mitigation and community and hospital-based intervention programs, that's if I had to guess, that is probably going to be the first avenue for a win. And so, certainly trying to use federal funding that's available to fund those programs, that seems like an avenue that, kind of skirts around some of the very divisive political issues. So it's kind of a winning avenue, and we have to find some. So
This is great. Representative Terry Cummings, your hand is up.
Yes, good morning. First, I think that this entire conversation has just been very helpful. And I'm really glad that Dr. Clark, who I serve with, is not only engaging in this, as she always has, but has a lot of good information. But my question, I've been listening to everybody, and I'm kind of hearing a lot of different things. I'm hearing the gun violence portion. I'm hearing the gun violence portion as it relates to spinal cord injuries. Then I'm hearing the impact of spinal cord injuries. And then I'm hearing needing additional care coverage for people with spinal cord injuries, which I'm guessing includes injuries that are not caused by guns, such as what happened with Christopher Reeves. So I'm kind of wondering, is the goal here to really focus on gun violence, or to focus on people with spinal cord injuries and get them more coverage? And I don't know if that may be more palatable for, Kemp and the Republicans, because I've noticed that he's still kind of hooked, the governor is still kind of hooked on pathways, but he's providing additional funding to expand it via certain pilot programs, like he just did for additional counties who are, it's a prenatal visit pilot program, and then he expanded more money to expand cardiovascular and high-risk care services at designated perinatal centers throughout the states. So is there some way that we can weave in additional coverage for people that have spinal cord injuries, regardless of how they got that injury, and then maybe come back to the whole, I got this injury because of guns, so now I need additional coverage? And I was
Let me speak to that first. I mean, as the president of the United Spinal Association in Georgia, and we have 15 peer mentors, and maybe a third of them are from gunshots, but everybody else is from different injuries, and those people need peer support too. So I'm certainly open to that. Strategically, we were thinking that maybe going through gun violence, because it's such a public health issue right now, but no, I wasn't really thinking as much about the politics in Georgia. Of course, I was figuring out what the barriers were between Jasmine and other people, telling me what's happened in the past. But that's certainly a strategy to consider. And although we focused on the price for spinal cord injury, some people have brain injuries as a cause of their injuries, or combined spinal and brain injury. So I certainly would like to throw the population of brain injury in there too. And thirdly, although they have mental health peer services, you don't have to be physically disabled to have a disability as a result of your gunshot, because PTSD in itself, or pain, a lot of people have pain that's invisible. They move around, but the pain is debilitating. So there's this pain, and there's the psychological, emotional issues of other gunshot survivors. And so unfortunately, the invisible injuries and mental health, just doesn't get the focus that it should, because sometimes the physical aspects, although they're, I'm going to say pain in the ass because it's easiest to speak in that vernacular for us. And I work with injured veterans too, and it's often that it's the emotional and psychological injuries that create more problems. I deal specifically in relationships, right? So a couple that's doing well in their relationship can deal with the physical aspects. A couple that's struggling and has a relationship strife, that gets harder to deal with everything. So thank you, Terry or Representative Cummings, for that suggestion. I'll turn it back to
Yeah, I'm just kind of
Jasmine.
thinking that, Governor Kemp, he's out. So right now he's a little bit focused on his legacy also. And that's why there might be a end. And Representative Clark can, speak more to it. But because of that, I'm just wondering, like, is there a possible way in, even if it doesn't address everything, it could possibly bring some help and relief to, people living in Georgia that are dealing with these issues, right? These catastrophic type of injuries, regardless of how they occurred, right now.
Yeah, I think so. To your point, I completely recognize it. We sit in the same chamber, so I recognize it. One of the things I will say is the Colorado model of just creating a blanket term for community health worker, and then defining that to include different groups is one way of doing this. But the reason why I was focused specifically on gun violence intervention is because of the fact that I think there are people that would argue that there are services out there for people with certain types of injuries already. Now, there are probably people that will argue they're inadequate, but this would be specifically, if we did it this way, it would actually create an avenue for victims of gun violence to not only be supported, but also to be the supporters in that realm as a peer specialist, because peer specialists are specific. You have to have a shared experience. And so, I'm not saying, I think what you're saying is very apt. I also think what you're saying is very realistic. I'm not opposed to pursuing this in any one way or the other, but I do want to make sure that the population of people who are victims of gun violence, who are the ones that are receiving these interventions, that they are the ones that they will get the supports that they need for this. This is like a small, teeny tiny population, because a problem is every time you expand and get a little bit bigger, someone finds a reason for why we shouldn't do it. But I 100% agree with you. I understand where you're coming from.
Thank you.